Okay, Dr. Ahmed.
Through video.
Yeah.
Good afternoon, everyone. First of all,
Good afternoon.
please let me thank the organizing committee for including me in this very prestigious conference, and above all, Professor Hisham Al-Ghazali and my dearest friend, Professor Basser Rif'i. My name is Ahmed Al-Balot. I'm originally from Alexandria in Egypt, working as a senior consultant and deputy director for gynecological oncology in Frankfurt in Germany. The clinical implication of molecular classification in endometrial cancer. I hope that after this lecture you can answer these addressed questions and whether do we need a molecular classification of endometrial cancer, and what is actually the difference and what is new, and how to classify these tumors, what are the microsatellite unstable tumors, and what are the new algorithms and how to make all of this, and at the end to answer this very important question, what is the clinical implication of this new classification. First of all, please let me tell you that it became a reality. So after the new published guidelines of the ESGO, the European Society of Gynecological Oncology, with the ESTRO and the ESP, Pathology, European Society of Pathology and of Radiotherapy, they published the new guidelines for the management of endometrial cancer, and that's why the molecular classification, it's not only a research on a genetic level, but it became a reality in our daily routine. Any classification system needs to help us to give the right therapy for the right patient, and to make the correct diagnosis, and to identify the groups of patients with the worst prognosis, and to see whether specific treatment and whether this new classification will have a predictive value addressing the therapy. So to make this somehow realistic and practicable for you, I would like to give a case presentation of some cases of endometrial cancer in order to see what are we doing right now and what we'll be doing differently in the future. The first thing is the first case. This is a case, for example, of a 51 years old female with a PT1B endometrioid tumor. That means it invading more than 50% of the myometrium, with no lymph node affection and no lymph vascular space involvement. But this tumor it was a high-grade tumor with an aggressive pathology under the microscope. So actually speaking, how would you classify this patient? Would you say it is a low risk, or it is a high risk, or intermediate risk patient? Directly another example of a patient, a 69 and a little bit older female with a 1A tumor, that means only affecting the endometrium, also with no lymph node affection and with no lymph vascular space involvement, but a G2 tumor. So a little bit moderate in the pathology, and a little bit older, the female. So how do you would you classify this? Actually, the whole classification that we've been doing in the last 10 years was basically on a clinical pathological level, and the whole paradigm in the treatment, there was a shift after the publication of Bockman that published the dualistic model for endometrial cancer. We do know that we do have two types of pathology. The type 1 tumors, the endometrioid tumors, they account about 70% of the patients. These patients, they are more or less older. This is the typical type of endometrial cancer. They do have endometrioid pathology, and these patients, they have the metabolic syndrome. They are obese patients, and they do have more or less a favorable prognosis than when they are compared to the type 2 tumors. The type 2 tumors, they account about 30 to 40% of the cases. They do have non-endometrial pathology like serous papillary or clear cell tumors, and they do have worse prognosis. So the whole decision was based on this histological classification, because we noticed that the patients having an endometrial pathology, they do have a favorable prognosis in comparison to serous papillary and clear cell pathology, and also the tumors G1 and G2, they do have, as you can see from the Kaplan-Meier curves, a favorable prognosis, and that's why we had, if we put all together in groups, so we had a low-risk group, we had a high-risk group, and the so-called high-intermediate risk group, and based on this classification, we took our decision for the further adjuvant therapy. There are two other important factors, which are the extensive lymphovascular space involvement, as well also the mass of the tumor and its invasiveness in the myometrium. And as you can see from the different guidelines in the tables, we had different groups, and we had the low and the high risk as well as the high intermediate risk, and based upon all of this, it was a little bit complicated, but somehow we have put these patients into groups, and based on these groups we took our decision regarding the adjuvant therapy. But I have to say that have not been that easy for us from the practical point of view, as well as the improvement in the last years. So when we come to case 1 that I presented to you, so this patient has a 1B G3 tumor, so actually speaking, looking to the clinical pathological classification, this patient will have a high intermediate risk. That means the adjuvant therapy is indicated, whether an external beam radiotherapy or if you give a chemotherapy, but adjuvant therapy will be needed. When we come to case 2, for example, the 1A tumor G2, without lymph node or lymphovascular space involvement, actually speaking, this patient, according to the clinical pathological variables, will have a low risk profile, and at least in our German guidelines, we do not give any adjuvant therapy for this patient. But we know from the breast cancer, and I think that this Congress traditionally is really dominated with breast cancer and cynology, we know that this is not enough. And after looking to the genes of these patients, we could identify different groups of molecular classification, and we also knew that these groups will have different prognosis. For example, definitely we do not treat a patient with an luminal A tumor today like we are treating a patient that have a triple negative breast cancer or having a HER2 in. So, and as I said, this was not only, and this was very relevant, looking to the different groups. The same thing actually happened in endometrial cancer in 2013. In Nature, the complete sequencing of the genome atlas of 373 patients with endometrial cancer have been published. And as we expected, actually speaking, that we identified different molecular groups. And to make it short for you, the new groups that we noticed, there are 4 groups, or we can also say that this classification will have 5 groups, because in one group maybe we'll have patients having both characteristics. And what are these groups? The first group is the POLE-mutated group. The second group is the microsatellite instable. And we do have 2 other groups regarding to the copy number of mutation, the copy number low and copy number high group. And exactly like we saw in breast cancer, these groups had really different prognosis. They do have the same prognosis in the same group, but when you compare the different genetic mutations according to the new molecular subtypes, you will have different prognosis regarding different groups. When we look a little bit deeply to each group, the first group is the so-called POLE group. So this counts about 7 to 12% of all patients, and these are not only patients with endometrial pathology. There are also about 20% of the patients that will have other pathology, which is really interesting in this group. Although they are very, very ultra mutated, they do have lots of mutations, and they look very aggressive under the microscope. But nevertheless, they have a very favorable prognosis. It's very interesting because they do also have lymphosphere involvement, and they do have also lymph node affections. These group, as I said, have a really very favorable prognosis, and that's why many authors in the literature call them sheeps in wolf's clothes, because they look very aggressive under the microscope, but actually speaking, they do have a very favorable prognosis. And when you look to the older clinical pathological classification, then maybe you would rather put them as a high risk, but actually they do have a favorable prognosis, which is contradicted actually. The second group is the so-called microsatellite instable group. It counts about 28 to 30% of our patients. What is really important about this group is actually they are characterized with gene mutations that play a role in the DNA repair. We know the so-called mismatch repair, and when they do have, for example, mutations in the MLH1 gene or the MSH2 or the PMS2 genes, all these genes, they play a role in the mismatch repair, and that's why this group of patients, they would have also a risk for other cancers like colorectal cancer or ovarian cancer. This type of genetic mutation, when carried in the families, it is called the Lynch syndrome. The other important clinical implication that we know that some groups of drugs, they really works very good for the patient having or harboring these types of mutation, like for example the pembrolizumab. What is the Lynch syndrome? The Lynch syndrome, as I said, it is not only the genetic mutation on the somatic level, that means not only in the tissues and the tumor, but also carried in the germline, in the blood. And these patients, they will have in about 10 to 15% colorectal carcinoma, they would have endometrial and ovarian cancer. And when we look a little bit deeply in the Lynch syndrome, so we know, actually speaking, that in specific mutations like the MLH1 mutation, for example, the risk for having endometrial cancer will be up to 66%, and when you compare this to the normal population for 2.7%, so it's really a risky situation. Or for example, for ovarian cancer, they would have a lifetime risk about 20% compared to 1.6%. And this is a very important information because it amplifies the importance of identifying patients having the Lynch syndrome in order to perform, for example, prophylactic surgery, as the new guidelines recommend, for example, that after the ending the childbearing period before the age of 40, for patients having Lynch syndrome, the hysterectomy and bilateral sublingual oophorectomy should be done. And that's why they emphasize in the new guidelines only not making the immunohistochemical analysis, but looking to the family history and targeting with some target questions whether there is a colorectal carcinoma in the family or not. It's a very important piece of information that we need nowadays. Coming to the last two groups, the so-called copy number high, so this is more or less the typical one of the type 2 pathology. They are most probably having serous papillary or clear cell pathology, but we do also have in this group patients with G3 high-grade endometrioid. Up to or above 90% of the patient will have a P53 mutation that really characterizes this group of patients. The last group is the copy number low. About 40% of the patient, they're a little bit heterogeneous with different gene mutations, but till now we really do not know the real clinical implication of this group. Now coming to how to identify all of this, so there is different algorithms. For example, on the left side you see from the Canadian group, above all in Vancouver, they published their algorithm in order to molecularly classify endometrial cancer. On the right side, from Leiden in the Netherlands, the group around Kreutzmann, that they are also having a little bit different algorithm in identifying the patient with the POLE group patients. In the new ESCO-ESP guidelines, actually what the very important point, what are you expecting from your pathologist? You are expecting from your pathologist these new informations, which are the P53 mutation through immunohistochemistry as well as MSH6 and PMS2. And but not only you need the immunohistochemistry, but also you need to perform a genetic analysis to identify the germline and the mutation, and if it's there or a family history, you have to go for the germline. Okay, so now the question: what is the real clinical implication of all regarding the adjuvant therapy? The authors of the PORTIC 1 and 2 trials, they looked, actually speaking, and above all, to the group of high intermediate risk. So they basically included patients with different clinical pathological risk criteria. So you have patients, for example, with G3 tumors or 1B invading more than 50% of the myometrium, then were classified as a high risk, for example, or intermediate risk. But and now they look to this group of patients having the high intermediate risk, and they perform the molecular subtyping through the algorithm. And indeed, as expected, what happened is, actually speaking, you can really identify in this intermediate risk group patients that have favorable prognosis through the molecular classification, and patients that would have a worse prognosis. And the curve will be something like this, or was something like this. Actually, that means it made it easier to see that actually you don't have like three groups of patients, but two groups. Either the patient will have a favorable prognosis or will have an aggressive disease that needs an adjuvant therapy. Another important clinical implication is actually, as I said, in 2017, the FDA approved pembrolizumab as an immunotherapy, specifically for patients having a microsatellite instability, and we have growing evidence in the literature.
Okay.